ท้ายแล้วนะคะของ IAEA Expert Mission Strengthening Optimization in Radiological Practice นะคะเช่นเคยนะคะอาทิตย์นี้ก็ยังได้รับเกียรติจากท่านวิทยากรของ IAEA นะคะดร. Samuel Brady จาก Cincinnati Children's Hospital นะคะซึ่งก็คือครั้งนี้จะเป็นการ wrap up นะคะในสิ่งที่เราพูดมาทั้งหมด11อาทิตย์ที่ผ่านมาแล้วก็จะมาพูดถึงในเรื่องของ dose registration นะคะถ้าสมมติเราต้องการที่จะเริ่มเนี่ยเราต้องเริ่มยังไงหรือว่าพอเรามี data เนี่ยเราจะต้องinterpret data ยังไงนะคะแล้วก็มี special session นะคะที่แอบขอไว้ก็คือว่าอยากให้คุณแซมเนี่ยมาเล่าให้เราฟังนิดนึงในเรื่องของควร beam CT นะคะว่าbasic principle ของเขาคือยังไง pro and cons แล้วก็เรื่องของ radiation dose เป็นยังไงบ้างนะคะ Good evening Sam welcome to the last session the finale of the IAEA expert mission I cannot believe this is week 12 almost 4 months that we have done this thing so far together, right? And as usual, so this week is like a wrap up week. But before we go to the wrap up, you're gonna give. I gave you some homework about the cone beam CT that I want to learn a little bit more. Like, what is the cone beam CT and how we get involved? What is like the clinical usefulness of the cone beam CT, radiation dose or image quality, just like some background and a concept that we can learn about the cone beam CT. And next thing we're going to talk about the dose registration, dose index registration, how to start and how to interpret your data. And at the end, you're going to put like we talk a lot about your suggestion. You put a lot of comments on each modality that we talk about how we do the dose optimization, what should we do for the next step in terms of the dose registration or DRL and everything. So this week we're going to wrap up on those things. Then you're going to give us like a summary of the comments, and we're going to have more discussion with Dr. Panruethai, Dr. Jiraporn, and also Dr. Nucharin that he said he's going to come by us today. So we will see. So I give the stage for you.
Wonderful. Thank you. I'm glad to be here. It's I was just talking to Tanya before we started. It's amazing that it's been this long. It just every once a week, it doesn't feel like it's been a lot, but then when you look back at it, we've been doing it for 3 months.
Yes.
Yeah. In fact, 2 years ago, I was sitting here with you guys at the very end of my last time I was in Thailand, eating the best pad thai I've ever eaten in my life. I got to take it. Tanya and her mom took me out for some really good pad thai. So I miss being there with you guys. Thailand is such a beautiful, beautiful country.
Yeah.
And so hopefully I'll get to be back there next time. We can go get some more pad thai.
Yeah, sure.
All right. And so we had a last minute request, and I'm always excited to give requests because it's what you guys want to hear. So I love talking about things that you want to hear. And so we're going to talk not really in depth. We're going to just talk about cone beam CT that's used outside of traditional diagnostic radiology based CT. And so just very briefly, excuse me, what is cone beam CT? So what we're very familiar with, of course, is traditional CT scanners. You have the fan angle, so you have the wide detectors, and that goes kind of around the body as it spins around, but it's thin. It only normally covers maybe 4 centimeters. It could cover a little bit more, maybe 8 centimeters. Normally it doesn't cover a lot. And so it has to spin fast, and then the body has to translate through the scanner so that we can scan a large area. But in a different type of approach called cone beam CT, now we're going to use a wide angle, and that is so that we can cover a large detector. And this is, of course, we use this in fluoroscopy where we have these flat panel detectors at the end of a C-arm. And we're also going to talk about dental today. And this idea here now is we can cover in one image, in one projection, a large field of view. And so the biggest difference here is one, we cover a lot of anatomy in one spin. Now, of course, we can column it, so we can always pick how much we cover, but we have a maximally large area. And two, the biggest difference is the patient does not translate. So here you can see this kind of spiraling effect right here. That's because when you have a small detector to cover a large area of the body, you have to push the patient through. But of course, in this situation, such as with a fluoro unit, the system will spin around the patient, but the patient will not move and the machine will not move while you're acquiring the image. Now, if you want to do a cone beam of one location and then do a cone beam of another location, you acquire it, you reconstruct the image, you move the machine, and then you do it again. And so it's a multi-step process. So today we're going to talk about the two more common areas of cone beam CT application outside of quote unquote typical radiology. And the first one is dental. These are these cone beam CT scanners. They're dedicated. They're almost always found in dental clinics or units. And they're obviously, you can see it's a C-arm, very much like a fluoro system, where you have the detector on one side and the X-ray tube on the other, and the system can still spin around the body because of its geometry, and so we can get nice, good imaging of the face. And the other one, of course, as I introduced in the previous screen or slide, is used typically in interventional fluoroscopy. So now we're doing typical procedures such as stents, grafts, biopsies, maybe needle localizations. The most common are these C-arm units that are going to be mounted either to the ceiling or to the floor, and they'll be found in an interventional suite. A more recent development are these mobile C-arms that can also spin and create a cone beam CT. They're not as common. In fact, I don't know of many that are out. I don't even know if these are for sale yet, but they've been working on these for the last couple of years. And so probably very soon you'll be able to do cone beam CT in the OR or other surgical areas where you normally find mobile C-arms. But for the most part, we're going to talk today about the fluoro-based C-arm CBCTs that are found in interventional radiology. So let's start with dental. It's going to spin. The system itself will actually not go a full 360 around the body. It's going to go most of the way around. You need to acquire a minimum of 180 degrees. We've already talked about this when we talked about CT. And during this procedure, it's going to spin around your body and it's going to it's going to collect enough data to create two types of images, a 2D image and a 3D image. And we'll define that. We typically use this type of machine when we're obviously trying to image the oral cavity, but more specifically, we want to try to get the entire oral cavity. Whereas in intraoral dental imaging, you can obviously focus in on a few teeth, but you have to take multiple bite wing images to get the whole mouth. And at no point where you get the entire mouth in one exposure. So in this system, we can do the entire face in one exposure. It will, depending on the position of the system and the angle, also collect some information about the neck, the ears, the nose, or more specifically, the sinus cavities, and the upper location, the upper portion of the throat. Typically, in dental, we use CBCT for implant planning. I should speak very specifically to the US. I read several papers and I read a couple of different dental society, I guess you would call them white papers or policy papers, where they talked about where they recommend the use of CBCT. And probably the most common area, at least here in the United States, is for planning of dental implants. So if you're get all new teeth or get a new tooth placed in, or you're trying to restore a tooth that's been knocked out. In the past, it didn't really require it, but they've moved now such that they strongly recommend CBCT for all dental implant planning. Of course, you can use it for a lot of other reasons, such as visualization of abnormal teeth, the evaluation now, for example, of the jaw and the face, and cleft palate assessment. You could do it if you're planning for a root canal. And then obviously the typical things you would see on a normal intraoral will appear in this. You'll be able to see caries and other things. But obviously the geometry is different. And we'll talk a little bit about that in a moment. There's going to be, of course, probably the second most common use for this, I guess I should have put this on the list up a little higher, is when you have facial or dental trauma. And so you need to visualize the extent of the trauma with respect to the rest of the oral cavity. So as I mentioned, when this system spins around the face, it's going to acquire two types of images. The first option is a panoramic image. It's a two-dimensional image. It quite literally takes the three-dimensional image and it flattens it out into a two-dimensional image, as you can see here. So now you can see all the teeth in situ. You can also see the jawbone, obviously the maxillary, or some of the sinuses, and depending, you can see some of the ear canal and the throat. I just listed all that. The issue with this is when you take a three-dimensional object, an object that's in three-dimensional space, it's got an X, Y, and a Z coordinate system. And when you flatten it out into two dimensions, you lose spatial coordinate system. So if you want to know how far, the physical distance from, say, one tooth to the next, or you need to know a length, and so you need to make a physical measurement, you can't technically do it on the image itself because there is no way to know exactly how many millimeters the image presents at how the image presents in millimeters or centimeters, etc. And so the only way to do that is you actually have to place opaque markers. And if you place two opaque markers, say on the face, and you know the exact distance of those opaque markers, then you could measure those opaque markers in the panoramic image, and then you would have a coordinate system so that you could then make other quantitative measurements. See, the reality is that almost 85, so about over 83% of all panoramic images have errors that exceed a millimeter. In other words, there is some accuracy that you can get from this, but there's also some inaccuracy. And so if you're really wanting a quantitative image, panoramic images are limited. And then, of course, probably the other major some of the other major limiting factors are, depending on how you position the patient and the type of equipment you use, each machine is going to have subtle differences in its geometric differences, its distances, the way it angles its X-ray tube to the detector. All of these things are going to cause discrepancies in how the image appears. And that's why it's not very quantitative. Probably the other big one, and this graphic was a little bit out of order here, is the fact that when you look at the panoramic image, of course, you're getting a nice coronal view of the face, but you actually can't see down. So you can't get the bucolingual view. So you actually can't see like the crown or the top of the tooth. So that brings us to the other way we image with a CBCT dental system, and that's creating cross-sectional 3D images. So obviously for the same sweep, for the same acquisition, you will be able to also produce thin section images. Obviously, the main advantage of this is you get your reformats. You get your axials, your coronal, coronals and your sagittals. You will have a nice quantitative, because it's in since you preserve the three-dimensional volume, you know what the distances are, so you can actually quantitate the image. So if you have some kind of trauma and you need to make measurements and you need to know kind of precise locations and how big, say, a tumor is, or how big, how much trauma there was to the face or the jawbone, you can actually start making those measurements now, because there's minimal distortions, and there's obviously this is sliced, so it's just like a normal CT scanner. It comes in image slices. You can you can sort through those, and you can go in and out of all those different sources. And so there's really no tissue anatomy that's superimposed over the other, like in a panoramic, which is just a two-dimensional image. So the question then is dosing. So we'll talk about this kind of in a couple steps, but generally speaking, dental CBCT, so the dental acquisition, is a lower dose than traditional CT. So if you go into, normal CT scanner in radiology and you do a maxillofacial scan or even just a more localized scan of the oral cavity, that scanner, the CT scanner, is going to produce a little bit more radiation. It needs to, obviously. The volumes are different. The geometries are different. That the scanner is so much bigger, it needs more dose to go all the way from the X-ray tube through the patient to the detector. Comparing that to the smaller system that quite literally just spins right around the head, because of the fact that the dental CBCT systems have closer geometry and they're smaller, they don't require as much MA. And so the dose to the patient can be a lot lower. That said, these dental CBCT units are more dose than an intraoral dental imaging exam will ever produce. So here are some numbers. These are numbers I actually went out and measured so that we could just kind of talk about them. So we're going to compare a digital intraoral. And I know there are film intraorals that are still being used quite extensively here in the US, and I know in Thailand and probably all over the world. Film intraoral is still a little higher dose than digital. So for what it's worth, I only had access to digital systems, so my measurements are going to be probably lower if all you use is film. But know that still film intraoral is lower dose than dental CBCT. So I just had to make that statement. So we're going to compare digital intraoral. We're going to compare a standard panoramic image. So it's a spin around the face, and then the image is then displayed in 2-dimension or flat. Then there are more specialty imaging where you're actually doing a rotation around the face, but the axis of rotation isn't centered in the body. It's centered on either the left or right TMJ. So you're doing more of a jaw. Of course, you're looking at the hinge point of the jaw. And then what would it be for a 3-dimensional tooth or 3-dimensional acquisition of the face? So we have our typical dose metrics of air kerma. And then we also can make either the CAP or DAP measurement. So now that takes into account the air kerma times the area of the exposure. And then very specifically for the CBCT system that does 3-dimension, those systems will oftentimes provide you a volume CTDI calculation, something that you could use in a small way to compare back to regular CT scanners. So looking at air kerma values, you can see that the digital intraoral is usually about 0.1 to 1.3. So that is pretty slow. The 0.1 is on the low end. 1.3 would be maybe if you're doing like a molar or just something that's more dense, so you just need a little bit more MA. Standard panoramic, once again, that just depends on the geometry and the size of the patient, but smaller patients, even the smaller patients that we image in our clinic, will get about 0.7. So nearly 7 times that of the smallest if you're doing like say an incisor or something for an intraoral. And then TMJs, they're low dose because they're focused. The system's offset and you're only imaging a small volume. And you can see that here with the CAP. Now, when you start to put this in kind of order, the digital intraorals, they'll scale somewhere between 3 to 33 milligray centimeter squared. So air kerma times area. Standard panoramic, now we're getting higher. I guess TMJs are lower. But when you compare the intraoral to the panoramic are higher. And then when you get to the actual cone beam, the 3D, because you need really good resolution and you're trying to get really good detail of the whole intraoral cavity, the dose is just going to be a little bit higher. And so it can get all the way up to a CAP or a DAP of say 542. So obviously several magnitudes of order higher than just a standard intraoral exam. And then, of course, the volume CTDI. These values may seem high. 10 milligray for a CTDI vol is actually really high. But when you realize this is not patient dose, remember, volume CTDI is never patient dose. It's a machine output. So that machine output is to a 16 centimeter CTDI phantom. And so when you consider that, most face and brain protocols, so like a typical head CTDI is going to be in the 30s and the 40s. And a face is going to be usually somewhere in the teens, so maybe 15-ish to 20. And so when you consider what we're doing down here from 4 to 10, that's actually a pretty low number. All right. So let's also try to put this a little bit into perspective. Now, I know we don't use effective dose when we do diagnostic reference levels. So really what I'm trying to do is just talk about the previous screen were doses to machine. They were machine doses. They were machine output, stuff you can measure with an ion chamber. Now, how would you equate that to patient population dose or risk? So trying to put this into perspective for risk, a typical intraoral or a bite wing exam, we do a lot of these here in the US. There's just, there's about 400 million of us here in the US. And basically every person should, not everyone does, but everyone should get a set of intraoral or bite wing exam images every year. So there's not quite all of our population, but a good fair amount of our population get these every year. And so when you look at the standard circular collimation on the end of these intraoral systems, you're talking about 36 microsieverts. So it's about 3.5 days of average background. If you use a collimator, which I recommend, we're actually in the process of publishing a paper on this, talking about this, it reduces the dose substantially. Now you can see this individual holding the actual imaging plate. It could be either a piece of film or a digital like CR plate that is what is used for imaging bite wings. You can see that the collimator is made to be the same size as the detector. And that is why the dose in these rectangular collimations are only a fraction of the circular, because the dose that goes out of the tube onto the detector matches the detector. Whereas with the circular system, the detector is only actually about 1/3 of the volume that you're covering. And so the whole reason that we use these large circular is so that you don't have to be very accurate where you place the X-ray tube when you're imaging in the teeth. And so with training and with some experience, when working with our dental hygienists and our dental technicians, the people that actually take the X-rays, they've gotten to be really good because there's ways to align it. There's tools that help you align it really easy. So you put the tube in and you can get it aligned properly, and you pull the trigger and there's not a lot of cut. With experience, there'll be no cut. So, or image cutting or loss of image. So that's something that we just always talk about. I always advocate, if you're trying to reduce dose, especially in an intraoral circumstance where most people get intraoral scans every year as part of their dental hygiene, you should try to make it as low as possible. And that's kind of the same concept as mammography. We recommend all women get it after a certain age. Well, if that's the case, then we should make it as low as possible to keep everyone as safe as possible. So how does a panoramic compare to that? Well, in the US, we only perform about 21 million of these a year. That's about 7% of the overall dental population being imaged. So if about 300 million Americans get an intraoral exam a year, only 7% of them will ever get a panoramic exam. The doses here now, you can see for an adult about 25 microsieverts and a pediatrics about 14.3 microsieverts. So about 2.5 to 1.5. And then the CBCT is even less used. We only do about 5.2, 5.5 million of these a year. So only about 1.7 or 2% of the entire dental population gets one of these. And here the doses are much higher to the population, 177 or 180 microsieverts, which is approximately 18 days of natural background radiation. And here you can see the pediatric population gets basically the same. So there's not been a lot of optimization in the usage of CBCT because it's just not really used that often. So doses are pretty much the same for kids as they are for adults. Part of that is because as we all know, bones and teeth, they basically are as hard, by the time we get, our bones, for example, by the time we're about 8 or 9 years old, are as ossified at 8 or 9 as they are when we're adults. And that's so when it comes down to imaging teeth and the bones in the jaw, there's really no distinction between a kid and an adult. That and our faces, they grow logarithmically. And so usually by the time we hit 8, 9, 10 years old, our faces are getting large, are approaching about the same size as our face that we would have, the rest of our adult life. And so that's why there's very little, I think, modification when it comes to this. That said, there's still a lot of room that we can modify. Obviously, we can modify it when we do panoramics. They reduce them by about half. So I would argue there's still room to modify in CBCT. But once again, we just don't really do that many of them. So I think no one's really tried. So, when you look at the Thai DRLs, so tying this all to, you guys have done a lot of great work back in 2017 collecting data for intraoral. So looking at, of course, the various different teeth or intraoral examinations. You've got your DRLs shown here at the 75th percentile, and it shows with the Arakerma. So that's great. And you both did it for digital and for screen film. And that's wonderful that you distinguish between the two, because of course they are going to be subtly different. Film is always higher. As you can see here, it's about 2 times as high as digital. Now, of course, you don't have any CBCT or panoramic, and that's fine because we don't have that here in the US. My guess, just population-wise, we do more, but even then we don't do it because it's such a small population that get the panoramic and CBCT. That said, it's also very helpful to start tracking those numbers. So when we started tracking these numbers back in 2016, that's when we started to realize the discrepancy, such, for example, the CBCT there is no dose reduction or any dose optimization for kids. And these doses are obviously much higher than the intraoral. And so starting to collect the data is very helpful. You might not actually publish DRLs anytime soon, but as you start to get you should start sending out surveys. And as you survey for the intraoral, it would be helpful to at least start asking, how many panoramics a year are performed, and maybe what's the average output. And then as time goes on, you can start maybe actually including that as a specific question, getting specific survey data back for maybe an average size adult panoramic and an average size adult 3D tooth or something like that for the CBCT. And I would imagine the vast majority of the dental clinics that send that data back to you guys for processing would probably mark not applicable, but you will start to see that and start collecting that, especially maybe in the larger regional areas, throughout Thailand. And you can start to collect that data towards setting up a DRL. So now shifting gears real quick, let's talk about CBCT in interventional fluoro. We kind of already did talk a little bit about this when we talked fluoro about a month ago. We actually talked about it when we compared interventional fluoro on a traditional CT scanner versus CBCT fluoro in a traditional CT scanner versus a C-arm system. So I'm not going to add that much more information, but I wanted just to talk a little bit about some new, actually very new technology that we've just been testing and working with Philips to develop. So let me get to that. So obviously, what are the uses? You could largely group these two. The use of CBCT in IR in angiographic and non-angiographic procedures. My personal experience is on the non-angiographic, where we do a lot of biopsies in our pediatric hospital. And so I would say I've worked the closest with our IR docs trying to set up good dose reduction and imaging practices for our cone beam CT acquisitions. What are the primary advantages of using CBCT over traditional CT scanners? So C-arm versus traditional CT. The C-arm system has a better, higher spatial resolution. And it's because of the type of detector. It's a large, flat panel, really small detector elements, teeny, much smaller than the actual traditional CT scanner. And so you get really good spatial resolution with the C-arm CBCT systems. The primary limitation of these, however, is that they are slow. It takes about 8 seconds to do 3/4 of a spin around a body. So if you're doing, say, a lung localization, you're doing a CBCT for lung localization for needle advancement, it'll take 8 seconds. If you do it for the body, it'll take 8 seconds. The only difference is typically when you do a head, because it's smaller, and because the system is at the end of the table, at the head, you'll do what's called a propeller, where it'll spin around quite literally like a propeller, like an airplane propeller, and that will go around real quick, 4 seconds. But when it's in the traditional situation where it's going to spin around the body in a C-arm motion, it can only go about 8 seconds. So it's slow. Therefore, if there's breathing motion, cardiac motion, or even just physical motion, even though most of the time these patients are anesthetized and they're out, but if there's ever any kind of motion, that's going to cause blur. There are lots of artifacts in these systems. We've already kind of talked about them with the fluoro unit, so I won't get into them, but we're getting better. We're getting a lot better at fixing the look, the quality of the image, but there are still artifacts that are hard to clear up. Now, what I mean by smaller field of view is the detector itself is larger than an actual traditional CT scanner. So per spin, you get a pretty large field of view. The difference is a traditional CT scanner can raster or scan through the body. So if you want an image of the entire chest, or at least the whole lung field, you can do that in less than a second on a normal CT scanner. But in a CBCT, because of its limited field of view, you can spin once, but if it's a large chest, you're going to have to physically then move the system and spin again. So you're talking a matter of minutes to acquire the entire setup of the lung. So typically what will happen is, if you're doing a biopsy, as an example, you basically know where it is because they've already done some other imaging and MR, CT, et cetera. And then you kind of know where it is. So they will position the system centered on that and spin there, and it will never move. It just basically stays in that same location and keeps imaging the body. The overall contrast to noise ratio for these CRM CBCT systems is about 1.5 to 2 times lower than traditional CT. So if you're really used to looking at that really good, beautiful gray, white, black grayscale values and good contrast, low noise contrast in traditional CT, these images will not look that good because the contrast is lower, and we typically don't really use that much contrast. You can do contrast injections, you can, and that is done, but it's not as typical as is in traditional CT, where we almost always use contrast, IV contrast. All right. So historically, how were these systems used? Historically, if you were going to do some kind of preoperative planning or biopsy, you would actually use a traditional CT scanner. You do the normal workup on the CT scanner. You would then take the patient up to the surgery suite, or the interventional suite, and then at some level you would fuse the 3D data from the CT scanner with the 2D fluoroscopic data that you got in the room. And the technology is pretty good about doing that. And so for a lot of people, that's what they do. They don't actually do a lot of CBCT in the room. That said, some will still do the traditional CT workup. They'll get the patient in the room, do a single CBCT, and then they'll fuse the 2 data sets again. Or they'll even fuse like an MR set. And so they're really only using the CBCT scan as a way to fuse other data sets. So that's historically how we've kind of done it. But in the last couple of years, I would argue that the technology has become so much better and the reconstruction algorithms have improved such that we, at least at our institution, I can speak for us, we mostly do all of our work in the interventional suite. We do not take our patients down to the regular CT scanner, do all their imaging, take them up to the suite, do all their procedure, and then take them back to the CT scan, system to do their follow-up. What happens now is the patient comes in, they're prepped for surgery or the procedure, they're anesthetized, they're there, and whenever there needs to be volumetric imaging, we do the spin, we do the CBCT spin, and then they'll do the localization, they do whatever they need, and then they'll flip back over to just traditional fluoro mode, and then they'll perform whatever procedure they need to. And so oftentimes we will actually bounce back and forth between doing these spins. So this is a Philips unit. We have Philips at our center. So they call it Expert CT. And so that's why you see Expert CT roll, 8 seconds. Excuse me. So typically you'll see that Expert CT roll 1, 2, maybe even 3 or 4 times in an actual procedure. And then you'll find these 2 frames per second right here. You'll see these fluoro acquisitions kind of intermingled between it. And so that's what's beautiful about using CBCT in an interventional suite is you can do volumetric and then flip back to 2-dimensional imaging just really quick. It's just a button push. And we do that a lot for acquire the imaging, doing all of our planning of our localization planning for needle trajectories, so we can do biopsies as an example. So comparing the doses to the CBCT scans on a C-arm interventional system compared to what we would actually acquire on a traditional CT. Traditional CT is shown here in orange. And the, sorry, I got a dust bunny or something in my throat all of a sudden. It's kind of itching my throat. And the C-arm CBCT is shown in blue. And so you can see that for the most part, they're pretty much the same. The biggest difference, and that's what these solid blue values are, is we will, as you can see here, we'll do sometimes 4, 5, or 6 rolls. And so when you start adding them all up, of course, they're higher dose. And that's why they're up here. But when you just compare them 1 to 1, one CBCT to one CT, you can see that they basically overlap down here. So the one thing I wanted to talk about is kind of the new technology that's come out. Actually just barely did this. We were working with, like I mentioned, we have Philips technology. So I'm not trying to advocate that they're better than anyone else. I'm just saying that I've worked with Philips. And we were working with them, and they have typically only had one protocol for CBCT, for one spin. And they called it their abdomen protocol for whatever reason. And so if you did a CBCT of the chest or the abdomen or anywhere in the body, there was that one protocol. They had, I should say they have one for the head, but we're not talking about that today. And those doses were just a lot higher. And they only have it for adults, period. And so we challenged them and asked them if they could come up with a lower dose protocol meant specifically for doing imaging of the chest or lungs when we do all of our lung biopsies. And they came up with 4 different flavors or 4 different options where you get a new chest or lung CBCT at its normal traditional dose. And then they also provided options that reduced 25, 50, and 75% dose reduction. So here you can see the results of the new sequences. And the one on the left right here, this 100% abdomen, that's what we've been using for years and years and years. That's the one. My guess is if you have a Philips system and you do it CBCT, that this protocol is the one right here. Is what you use. And we took our anthropomorphic phantoms, our adult phantom and our 5-year-old phantom, and we put a bunch of our detectors in them. And we measured all their organ doses, and we calculated the effective dose for those populations. And once again, you basically see that the doses are kind of the same. And that's just because there's never really been any consideration to modify the radiation output based on if it's a small kid or a big patient. And so here, fast forward to the next, or going over to the right, this right here is their new protocol meant for use in the chest when we're doing lung localizations. And here you can see for the adults, you can see there was about a 30% dose reduction. And what's beautiful here now is they were able to make the modification so that for a smaller patient, the system is more aggressive at dose reduction. And here you can see the patient, a 5-year-old gets a 60% dose reduction. And then if you start to look at their 25, 50, and 75% reduction protocols, and they actually don't go that much lower. So even though they call them 25, 50, and 75% reduction, we actually don't see a 75% reduction from this bar plot to this bar plot. We do see some more. It actually reduces it by about 20%. So for what it's worth, we only use this protocol now. We use the one on the left for our typical abdomen or body imaging, and the one on the next to it, right here to its right, we use that for all of our chest lobes. The only reason I bring this up is that we do a lot of we're starting to do a lot more CBCT. I believe the whole field, interventional fluoro, is moving this way, and I believe that that's it. We've come to that tipping point where we need to now start to ask the vendors to produce low dose, better optimized protocols for routine use of CBCT. 20 years ago, we were imaging kids and adults the same, roughly the same, in traditional CT. There were really no considerations for pediatric imaging. And then obviously we realized that we were overdosing kids by 4 or 5 times as much. So fast forward now, our kid doses are so much lower, and so are our adult doses. We're at that same point now for CBCT in the C-arm or the interventional fluoroscopy system. So real quick, obviously we've talked dose. I've been talking about dose reductions. The images on the bottom come from the old protocol that we've always been using, the quote unquote abdomen, and the ones on the top are the new chest or the lung protocol. And the columns, so A, D, B, E, C, F, those are kind of paired in age, as best as I could. You know, this guy's a 7-year-old down here, and this is a 13-year-old, so not exact. But this guy over here is a let's see here, where are you? C is a 5-year-old, and F is a 5-year-old. So those two are 5-year-olds. But the point here is just at first blush, kind of looking back, leaning back, I would argue the image quality is the same. We measured noise, we measured a couple of other metrics, and it is true. Image quality is basically the same. Noise is about the same. Contrast to noise resolution was about the same. The ability to visualize the pathology of interest, in this case, the tumor, was all the same. So there is a lot of room for lower dose CBCT is, I guess, the overall conclusion that I would get to. All right, so that's really what I had for this.
Thank you so much, Sam, for clarifications. So this means actually I saw, and I think like we work with the cone beam CT for a while, because in the neuro IR, when we do the angiogram, and a couple of times we have like the spin images for the aneurysm after, like before or after clipping. So that is a cone beam CT image.
Yeah.
Wow.
So
okay.
yeah, we've definitely done a few in the. I would say neuro probably was a little bit quicker to adopt CBCT, and that's obviously because it's easier to do a spin of the head. It's because you could just position it at the end of the table, and the system can quite literally just go right around it real quick, and it creates a very nicer looking image because of the way they can acquire it. But now that it's getting more popular down in the chest and of course the abdomen, the pelvis, there's a lot of room for continued growth and development.
Yeah. So which means, so if it come to the dose, like the dose registration or DRL things, how so do we do the separate for
Yes.
the IR? Okay, like one part is like for the CT part, and another part for the IR, like for the fluoroscopy.
Yeah, and you guys have started already collecting what we've talked about, and we'll actually I'll share with you again your DRLs for interventional.
Yes.
And cath really doesn't do it, but interventional IR. So the answer is you could start doing the surveys and start asking those questions. You know, what is your typical CBCT of, say, neuro and body? And that's good information to start collecting. That said, you once again, it's very specific. You know, biopsies, we use it a lot. Other, you know, when you come back to the different usages, you probably won't use, you know, stent graft placement, maybe one, thrombolysis, sorry, I can't speak. You might not even use a CBCT. So once again, when it comes to interventional, the type of procedure is very specific to that. It's really hard to establish DRLs. And so it's even harder to then add the CBC to that. But if you're doing a lot of CBCT routinely, then you need to consider the fact that the overall air kerma value for the procedure is going to be skewed higher if there's a lot of CBCT. And so it's probably good. When the hospital sends the overall cumulative air kerma for, say, a biopsy, you're going to write that down. That becomes your DRL, and that's what it is. But you may also ask a follow-up question, you know, do you do CBCT, and what would be the typical CBCT dose for those biopsies? And it might be another, you know, whatever percentage of that. And then you would list that as separate. So you don't necessarily need to subtract the two. You don't necessarily need to take the CBCT dose out of the interventional procedure because it's part of the procedure. You want to kind of collect that. But you could list it separately so that people know that these are kind of the rough dose levels that you should still be aiming for when you do a biopsy if you include a CBCT.
I see อาจารย์มีคอมเมนต์มีคำถามเพิ่มเติมไหมคะ
I would like to ask that the radiation therapy also use cone beam CT, and is it the same as a fluoroscopy cone beam or not?
It is the same concept. The biggest difference is here. Let me just pull this up real quick. There we go. Can you see my Google page?
Yes.
Okay. So in interventional, I mean, all the different vendors, Varian, everyone, they all have different approaches. And they're going to have a flat panel on one side and a detector on the other, an X-ray tube on the other side. And this whole system is going to spin around, and they're going to still be able to do a CBCT or a cone beam. So everything we talked about is the same. The biggest difference is now your geometries are larger. So these machines are, anyone that's ever been in these suites, they know these machines are big. So the distance from the X-ray tube to the detector is larger. And the system goes really slow because it's a really big machine. And so the doses tend to be much higher. And because of the trajectory and the limitations of where they can actually image in the body, if you have a large body on the table, I don't even know if we have a picture of it. Well, that's not exactly a large person. But if you have a large body on the table, you actually have to shift the patient. You can't do, in a normal CT scanner, the field of view is large enough, you know, it's 50 centimeters. We can just one full swing, full spin, and you get a full 50 centimeter field of view. And these, the field of view is smaller. And so if you're doing, say, a liver imaging, you'll actually center the image or the center of the rotation over the liver. So the patient is shifted and you spin around. So you actually don't get the whole abdomen. You only get, of course, the liver. But because it's offset, you also get a lot of artifacting. I worked with a gentleman way back in the day, about 15 years ago, when they started developing CBCT for RO, for radiation oncology. And back in the day, it was hard to even read those images. But nowadays, the images are standard. They'll almost always, they will obviously take the CT scan, they'll do all the simulations beforehand, they'll come in, they'll get the patient placed in position, and then they'll do a cone beam CT to make sure everything's aligned properly. And they'll even bring in the true traditional CT, and they'll fuse the two so that they can actually do maybe Hounsfield U calculations to make sure the planning, the dose plan is going to be delivered properly. And then, of course, as they apply it, or as they actually go through and start treating the patient, they can at times set it up so that they can do live imaging. So you have the X-ray system going at the same time as the MV system, and that allows them to track, motion, if the patient's breathing, if the heart's pumping. And so they're actually able to keep the volume, the target volume, better centered. And so it's really amazing what they can do now in interventional, not interventional, in radiation oncology. That said, these doses tend to be a lot higher.
There is a couple questions. So one from the chat box. So if we want to compare for the dose metric on the cone beam CT to the conventional CT, can we use do we still use like a CTDI volume, or do we use a DAP to compare?
Yeah, I would use volume CTDI. So one thing I probably should have done is added one more column right here. So this would be your traditional CT. So when you're looking at kind of the face down here, just the mouth, we're talking somewhere in the 15 to 25 range. And the way that these systems are measured, or the way we calculate the CT, it's the same way we calculate CTDI. We're still using the same phantom right here that you see on my screen. These little 16 centimeters, the smaller of the two. And you place the same phantom on the machine. Here we go. Perfect. So what you do is you take this little blue piece out where the patient bites, you just pop that off, and you take the CTDI phantom and you place it on it, just like as if there was a head there. And you place your ion chamber in it and you spin it around. The biggest problem with that is when these machines spin around, let's assume we had an ion CTDI phantom sitting right here, the machine doesn't do a full 360. It will do a part 3/4 of the way. So you can't, if you put your chamber in the dead center, you'll get one measurement. And if you put it over on the left, you get one, and you put it on the right, you get a different. The numbers are different. If you put it in a real traditional CT scanner, because it can go all the way around, the left and right numbers are almost always the same. So when you do the CTDI calculations in these machines, you have to be very careful how you set up the phantom and where you put your ion chamber to make all your measurements. That said, it's the same calculation. When these numbers, this 4 and this 10, I actually physically measured using my phantom, my 100 millimeter or my 10 centimeter ion chamber. I did the rotation, I did all my averages, and I still did the same calculations.
Mm-hmm.
So it's probably the best way. If you're going to compare CBCT, use this CTDI vol. That said, there is no volume CTDI calculations for panoramic images. So the only way to compare those are DAPs, but you're only comparing a panoramic to, for example, an intraoral.
Mm-hmm.
And should we calculate the DLP from the CTDI volume and the length of the receptor?
The answer is no. And that is because for these systems, it's a single rotation. You cannot collimate the field of view. It is one field of view. You can, when you're imaging here, the only thing you can change is the area of focus. So you might be able to come over here and you might be able to center like on the front tooth or the front left, front right, or you know, the system, because of its limited field of view, you're only going to be able to image maybe part of the face. And if it's a small enough face, then you can get the whole thing. But you know, right here, you can kind of see this blue, green, blue. You can see how it changes the kind of the area in the front or maybe the sides. That said, this is actually a bad graphic because you can't collimate this way. It's always going to be the same size. It's always going to be the same size. You would never be able to do that. So this is a bad graphic. I don't even know what they're doing with there. So the answer is you'll never have a DLP. No DLPs in this.
I see. So there is another questions from the Facebook Live. So when we do the fluoroscopy in the IR suite with cone beam CT, so and is there any heat issue?
Heat
that
issue?
Can happen? Heat. I mean, like because when you do like a fluoroscopy and cone beam CT, maybe like in one patient you do like a multiple spin for the cone beam CT.
Are we talking like skin reaction?
Yeah, it's not like only the skin reaction. It's also like I think it's like the tube heat in the tube. Yeah, for the machine broken.
So the answer is yeah. No, the machine is fine. Yes, you are acquiring more images, but the fluoro, the dental, the X-ray tube in a C-arm fluoroscopy, these whoop, sorry. There you go. These X-ray tubes right here are actively cooled, and so you can use them. I mean, you may use them for interventional procedures for 2 or 3 hours. And so if you do one CBCT, it's not that big a deal. If you did 100 CBCTs, maybe, but no one's ever going to do that. But these systems, they're very good at keeping the heat down. So no, you shouldn't have to worry about that.
Okay. So
but then also just to talk kind of a little bit about the skin. So fluoro, of course, the dose is the X-rays are always coming in one angle. And so that's why we have to worry about the dose to the skin. But in CBCT, of course, it spins it around. And so now the dose is being distributed. So we actually don't worry as much about skin burns in CBCT. In that case, we're now worried more about the organ doses internal to the body. So that's a completely different discussion though.
Oh, that's good. Yeah. Okay. So I think we can อาจารย์มีคำถามอีกเพิ่มไหมคะหรือถ้าไม่มีเลยค่ะน่าจะค่ะ Okay. So I think we can move on to your next talk on the dose index registration, how to start and like how to interpret the data.
Sure. And so the one thing I would say is when we did talk fluoroscopy, which was about a month ago, we talked about doing all the CTDI calculations and whatnot in the IR suite. So that's why I didn't even talk about it today, because technically we reviewed that. So if anyone has any questions, they can go back to those slides. Sure. All right, let me grab the next talk. Okay, so now we're going to talk about today's topic, right? We're actually going to talk about what we're supposed to talk about.
Yeah. Hey, Sam, can I interrupt you one more question? So from the chat box, is the wide beam concept and 10 centimeter chamber able to apply for the cone beam CT? I think.
So the answer is yes. And that is because so specifically going back to these systems, the cone beam CT, well, whoops. If you focus on this middle picture, let's just assume this middle picture is the right one. The actual area, the field of view area, is small enough to fit in a 10 centimeter beam. There are limitations for the interventional system. We talked quite a bit about those. So the answer is it's not very accurate when you use a 10 centimeter ion chamber in the interventional system. But like I said, go back to those slides. We talked quite a bit about that, and you'll know. But for the CBCT system, the area of the field of view is usually smaller than 10 centimeters. If it's not, then the answer is these numbers that I gave you in this right here. What you do is if you go into your system and you measure the field of view area, what you can do is I take some radiochromic film. So radiochromic film is something you can just go online and buy. It's really easy. Good heavens, what is the name of the company? Ashland. Ashland is what the company's called. Well, here's a picture. You can kind of see that it's film that you can actually hold in this. It's not regular film that would develop in normal light. It's film that you can only develop when it's irradiated. So you can actually just tape it to the detector side. Where's my system? So you can come over here. You have the detector over here and the X-ray tube. So you would physically tape the film, the radiochromic film, to this side. Take everything out of here. Take the little stand. Take all that out. So it's just a clean shot. Acquire one image, and then what'll happen is you'll see just a vertical line, and that's the field of view. You'll be able to measure the top to the bottom. You'll know exactly how tall your system's field of view is. And then you'll know if your 10 centimeter probe, your ion chamber, will cover that, or if the field of view is larger, because maybe your system is larger. And if that's the case, there's nothing else you can do. You still use the chamber, you still make the calculation, but you just have to know then that when you compare these numbers, these two numbers will not be as accurate to compare, because a traditional CT scanner, typically when we're acquiring, when we're calculating CTDI for like a maxillofacial or a more coned in protocol, those are going to have maybe 4 centimeters, maybe 8 centimeter field of views, in which case they're always going to be smaller than the 10 centimeter scanner, unless you're using one of the newer systems, which is 160 slices, or 16 centimeters. So the answer is we could probably talk about that for another 10 or 15 minutes. If it's really the only tool you have, that 10 centimeter probe, so you use it and you make your calculation. I don't normally go and I compare my dental CBCT system to my traditional CT. I typically make these measurements, the ones you see right here. I make those measurements every year, and I make sure they're the same every year. So that's how I know my dental unit is performing okay. And then I make, of course, all these measurements on my regular CT, and I make sure those are staying the same. And just know that the CBCT unit used in dentistry is going to be typically lower than that of regular CT. All right.